This is early onset scoliosis, which is a different entity in itself and maybe more aggressive than the typical adolescent idiopathic scoliosis that we will talk about today. So that's important to distinguish. If a patient has a curve that's less than 10 degrees, which is often evaluated in our clinics, this patient actually has only spinal asymmetry in terms of definition of a spinal disorder, which really asymmetry is not considered any kind of disease or modality that is needed for these patients. The etiology of adolescent idiopathic scoliosis is, as the name implies, unknown. There is some type of genetic component. So when these patients do come to our clinics, it is important to ask if they've had family members, either siblings, parents, or uncles that have had scoliosis that they've known about. It probably is a dominant trait that is with incomplete penetrance if we look at it. There is thought to be also a developmental effect with hormonal imbalances and changes in the adolescent, as well as work into different types of growth hormone, as well as calmodulin, that all seem to play effect in the development of this abnormal rotational curve. There is thought to be some type of postural element as the growing spine does continue to have effect on the patient's overall posture. However, how much of the causal relationship is posture is unknown. It is pretty common. Patients and their parents will ask if the posture of the patient or adolescent is the cause of adolescent idiopathic, and overall you can safely say it is not. Equilibrium has been studied, and there have been found to be asymmetric sensations at the lower extremities when looking at vibration, and sensation is largely intact. Motor strength, usually in a physical examination, is intact in these patients. Overall prevalence, somewhere between up to 2 to 3% in the general population. There is a female predominance, 10 to 1, and 5 to 1 as the curve becomes lessened, but more severe curves are usually found with patients that are female. Overall, only really 10% of the patients will have a curve that is severe enough, and we'll talk about that in treatment, that requires surgical management or treatment with more than just bracing if needed. The important thing to talk about is how we measure scoliosis on imaging. On the right hand, this figure is a basic understanding of the Cobb angle measurement by Dr. Cobb himself in this paper. The upper level of the curve that is most tilted towards the concavity, the upper end plate is measured parallel. A perpendicular line is dropped from that superior end plate. And then the lowest level, which is the highest amount of tilt at the lower end plate towards the concavity, is measured in a similar way. Where those two perpendicular lines will intersect as shown, that is the Cobb angle. And it's not uncommon that we see not only single curves, but double curves in the spine, as well as compensatory curves that need to be evaluated. The patient's history when they do present to your clinic, usually these patients are screened in the school or as a part of their physical examination in the gym. And the vast majority of these patients come without imaging or are referred potentially without imaging, but because of the truncal rotation that is captured with a scoliometer, these patients are sent in. And so with the use of the truncal rotation scoliometers, it's been found that our referral patterns are largely dependent on that. There also is usually by a parent or the child themselves, adolescent patient themselves, is a cosmetic complaint. The most apparent that patients will complain about is shoulder asymmetry. There may be a scapular prominence with the truncal rotation or chest that can be visualized, although due to the nature of the rotation, usually it's the back that has the asymmetry, and so usually the patient sometimes may answer that they have not noticed any asymmetry, and it's the parent that worries about this. There is a component of back pain in patients with scoliosis, and this is largely overall a normal finding amongst this population. However, in the absence of imaging characteristics that are worrisome or physical examination that we'll talk about, it's unnecessary to perform advanced imaging, including MRI, in a patient that has a mild asymmetry or mild curve with axial back pain without any red flag symptoms. Moving on to discuss the physical examination, the things that would be worrisome is if on the skin you find cafe au lait spots, which may be a sign of some type of spinal fusion abnormality or dysraphism. This patient may warrant looking into advanced imaging with an MRI of their neuroaxis, looking for any type of abnormality of the spine with dural ectasia or tethering. The other thing on physical examination you do want to evaluate are any congenital problems that the patient may have had with development in their overall system, cardiopulmonary, kidney problems in the past, which may lead you to believe there may be something more congenital with the spine that may be in this patient, especially thinking back about the age. If that patient is younger than 10, that also is concerning. Pelvic obliquity, again, the hips, if you place your hands on the iliac crest at the most superior level, you may find that there is some level of pelvic asymmetry there. And then asymmetry while doing the bend forward test also is apparent in patients with any type of rotational truncal shift, and that can be measured with a scoliometer. The coronal balance, those can be usually performed with the shoulders and the hips. And sometimes you may have to use a Coleman block to see if there's any real significant amount of tilt in the pelvis as a part of the compensatory spine. It is also important to evaluate the patient while they're laying down, as well as standing, to see if there's any change in that. The hypokyphosis and the sagittal balance can be difficult to evaluate, but as we'll talk, this patient usually has hypokyphosis in their thoracic spine. Reflexes should be evaluated, and that is another sign that potentially there is something in the neuroaxis that is more concerning and should have an appropriate evaluation in these patients. This is a representative image of what that truncal rotation looks like with the patient's right-sided hump. As you can see, the rotation there. As a also measure of the coronal bend, you can see as the patient is standing, the left scapula has shifted over towards the medial side, or I should say towards the right, as a part of this rotational imbalance. So really the indication for advanced imaging in these patients, more than a scoliosis x-ray, is if you have a persistent painful scoliosis that the patient is especially complaining waking up at night and having difficulties, inability to participate in activities. In these patients and adolescents, your questioning has to be somewhat pinpoint to elicit the appropriate responses. It is important to ask the patients if there's any differences in how they participate in their gym or PE class, whether sports have been altered in any way. Unusual curves, so a left-sided apex for a thoracic curve is an unusual variant that necessitates usually an MRI to evaluate the neuroaxis, as that's been found to be associated with abnormalities. Larger curves in younger patients should potentially make you think about MRIs to evaluate for those. And obviously physical examination findings that may be worrisome or abnormal, because as the typical adolescent idiopathic scoliosis patient has usually a very normal neurosensory motor examination. And rapid progression of the scoliosis is something to consider. If the patient in your follow-up has rapid progression, and usually that's associated with patients that are younger in their growth and maturity. The patients that may be sent to your clinic with these types of issues may have these findings on MRI if they have something that's more than idiopathic scoliosis. It's syringomyelia, diastatomyelia, very rare, but can have spinal tumors that are causing a change in the biomechanics of the spine. And in the higher spinal segments, Chiari malformations are found. It's very common to find tether cord and spina bifida in some patients, as well as there may be soft tissue considerations such as a lipoma. This is what dural ectasia looks like on the left. You see that there is stranding within a high intensity signal in the cervical spine, as well as syringomyelia on the right-sided image in the cervical spine in a patient who was having an evaluation for a scoliosis. We talked about the important things about routine imaging and assessment is a long-standing scoliosis film that evaluates the entire thoracolumbar spine in both an AP as well as a lateral view. The Cobb angle is the most routinely evaluated assessment radiographically for these patients. It's important to understand, as these patients are initially seen and evaluated, diagnosed with scoliosis, their Cobb angle may be one of the forms to evaluate their progression of curve, and it becomes very important to have the same levels documented for your Cobb angle, as that can change the amount of measurement that's documented in their examination as they have a serial follow-up in your clinic, as well as understanding that there is a 5-degree normal variance for this curve measurement. So within 5 degrees is considered the measurement error. In addition to an AP and lateral, bending films towards the left and right may greatly help understand the mobility of the curve, whether it's the major curve or the compensatory curve. It is important to get bending films as well. The other thing to evaluate on X-ray is the Risser stage of development in patients, and this can be done by looking at the iliac crest. The Risser stages may give you an example of, understanding of how much the patient's skeletal maturity has developed. It was originally founded in the 1930s, so this is something that has been evaluated for decades, and the steps are divided into the ossification of the iliac apophysis, really into 6 stages. Stage 0 on X-ray would have no ossification, and so no apophysis is seen, whereas stage 5 is representative of the entire ossification. As you see on the patient's left iliac crest, the entire apophysis will be visible. And stages 1 and 2 are the stages that are with the highest amount of growth and acceleration of the curve. So it's important to understand, as we think about the curve progression in these patients, to see where their skeletal maturity lies. The Tanner Whitehouse skeletal maturity score is also a more functional and way to look at the amount of skeletal maturity that the patient has. However, it does require a little bit more of a workup, especially with the patient having a evaluation of chronologic and functional skeletal maturity using the hand x-rays as an evaluation and the different ossification that happens at that. The other thing to think about is ossification of the triradiate cartilage around the hip, which can be a sense of how much growth is left. If there's complete ossification, then very little growth is left in that patient. So in a patient with a scoliosis that's found to more than 50 degrees, more than 2/3 of those patients will have a progressive 1 degree per year problem. However, these patients can still have a normal life if treated without any management. Their pregnancy can be without any complication, no restriction. There's no increased mortality until really the curve becomes 100 to 110 degrees is where there's cardiopulmonary dysfunction. And there hasn't been any direct correlation between back pain, the magnitude of the curve or location of the curve, as well as the lumbar curves that are associated with the degenerative scoliosis can be found later in life. However, it's hard to predict which patients will develop symptomatic degenerative scoliosis, especially if that patient develops any neurologic or neurogenic complaints. So the risk of progression has been looked at in several different papers. This is a paper that's a classic landmark paper looking at these patients and RISR 0 and 1, and then in their later maturity in 2, 3, and 4. And the percentage of the curve that progressed really is with the magnitude and the age. So if the patient is younger with a curve that's 20 to 29 degree, that's the population that progressed later at the greatest amount. Again, if it's a patient that's under 10 years old, that's when you really worry that this is going to have a significant progression in the patient's lifetime. Also been a lot of work about how much and what the utility is of bracing moderate curves starting at 30 to 35 degrees. The rates of progression in these patients, braced and unbraced, really started to think about it in the 80s with multiple papers coming out saying that bracing does in fact halt the progression, with only 43% of the patients that had bracing with earlier models of bracing compared to what the modern custom orthotics braces can be developed rather quickly for patients and be modified as needed, compared to the untreated population, which continued to have progression at the values that we expected. In this series, 68% of those patients had progression. And the other thing that's been evaluated in these patients that do have bracing to treat their curves up to 50 degrees is that there's no progression in up to 82% of these patients if the compliance with brace wear is more than 12 hours a day, and no progression was still found in patients, although it was much less predictable with 31% of those patients if 7 hours or less brace wear daily. So compliance with brace wear is the biggest take home with patients that are treated with bracing. These patients, again, in our modern understanding, the Scoliosis Research Society says if there is 25 to 30 degree curve at presentation and the patient is RISR 1 or 2, It can be observed potentially if it's premenarchal, if it's less than 25. Once you get to 30 to 40 degrees, bracing is recommended in a patient that is RISR 1 or 2. Once the patient has reached skeletal maturity and you see they're in either 3, 4, or 5, that patient can be observed. The talk about surgical management is discussed really when the curve is over 45 or 50 degrees at either grade 0, RISR 1, 2, or in the skeleton mature patient that is seen. So if the patient is having bracing as their management, it's important to have a few points for parents, especially as they are going to be the caretakers of the patient who's undergoing the treatment. It doesn't eliminate the curve, and it will not make the patient's spine fully straight. The main goal of this is to prevent the progression of curve as the patient is going to have skeletal maturity. Pre-treatment curves may return after brace continuation. This has been found in the literature as well, and found that if you have a 23-degree curve, it is more applicable to have brace treatment with a treatment effect that's found than a more mild curve. If for say 12 degrees, that patient may not find that there is a response to bracing. However, again, the treatment goal is to prevent the progression. Nighttime braces not only can be used, but they should be used in the patients that are having curves and are younger, that are more severe. In terms of when to stop the bracing themselves, usually in RISR 4 in girls, as they will reach skeletal maturity earlier, and in boys will wait till we see a complete apophysis and discontinue brace after that. This is a Boston brace, which is typically prefabricated. It can be custom also. It really works by applying a corrective pressure on the convexity, and it has a cutout for that corresponding concavity, so that as it corrects, the concavity may fill into that space. The Charleston brace is another type of brace. This is usually used for nighttime. It's custom fit and has the patient's torso involved. In addition to applying the lateral force of the curve closer to the midline, the Charleston brace, it also has the ability to apply pressure to bend and hold the spine in an overcorrected position, which, again, the patient's compliance with this as they are able to tolerate it with sleeping is the most important thing. Another type of nighttime brace is the Providence brace, which is similar to the Charleston in that it does apply a hypercorrective force, but it is only feasible while laying down on their back. So the patient can't be a slide sleeper typically, as the Providence does slightly elevate one shoulder as it applies that curve. So it may be difficult for the patient to have sleeping on their side, especially with this type of brace. This is a case example, textbook example of a patient who initially was 12 years old, premenarchal, when they had a 30-degree thoracic curve evaluated with RISR 0 on figure 8. It can be seen that there's no apophyseal ring, although it's an incomplete view of the iliac crest. And with treatment, the correction was found to be 18 degrees with brace wear, and at 2 years post-menarchal, found to have a stable curve that remained at around 26 degrees. So again, we see that it's not necessarily treating the spinal curvature to allow for normal spinal curve, but rather preventing the disease progression as the patient is going through skeletal maturity. The indications, contraindications, I'm sorry, for bracing larger, more severe curves, 45 degrees. If there is thoracic lordosis or complete loss of the kyphosis, those patients need much more. And the braces, unfortunately, can't capture the sagittal plane imbalances as well as they can with the rotation and the coronal plane. Congenital curves usually require more than just bracing because of their biomechanical nature and structural abnormalities. These curves are more aggressive and tend to progress in a more severe way than adolescent idiopathic. And usually patients that are already reaching skeletal maturity in RISR 4 or 5 or 2 years post-menarchal, those patients don't have any benefit from bracing. And if we talk about surgical management, the patients that really have any type of surgical option talked about in detail are the ones that have a 45, 50 degree curve with either not reaching skeletal maturity or with failure of brace wear. There is a large component of this in which there is patients that do have cosmetic complaints, truncal shift and rotation, rib humps that are unacceptable. Sometimes those patients will be talked about, and usually they can be associated with more moderate to severe category of curvature, however, not always. If we look at how the patients do with their 80 match paired Lanky 1A and 1B curves, the patients post-operatively in these more mild curves had no difference in SRS 22 scores. The Cobb correction was 14 degrees versus 22 degrees in patients that had this type of correction. And the really limitation of this is that there was no long follow-up in the patients, and there was no osteotomies to correct the types of curves, and they left out 1C curves. However, the surgical goals really to arrest the progressive deformity is the biggest goal overlying, and that is shared with non-operative management to obtain a fusion that allows the patient to have a successful spinal biomechanics for their lifetime, and to as a third and last goal is to improve the deformity, and even to a lesser degree, as found by most modern day surgeons, is improving the rotation. The rotation can be very difficult to fully correct, as well as may need larger anterior procedures to really go after that. The options, the mainstay is posterior only approaches to the spine in correction and stabilization. Anterior procedures or combined anterior and posterior options are being employed, however, probably less so than compared if we look at 20 and 30 years ago. There are fusion-less options, however, most of these are only in the research phase and not routinely employed. Historical considerations of implants are important to know, but really these Harrington rods and hooks have largely went away for newer style pedicle screw implants, and because of the biomechanical superiority of these types of implants, it's important to know that most of the older implants are never used now. The pedicle screw is much more biomechanically advantageous than the hooks and the wires. And this figure on the right is a representative example of how hooks can totally fail and pull out of the spine, as the pedicle screw on the lower part of the image has stayed intact. The classification that we just touched on that is used most often is the Lenke classification, which builds on the more descriptive nature of the curves at the bottom left, where you have a single thoracic curve, thoracolumbar curve, lumbar curve only, or a double major curve. And Dr. Lenke's classification expanded on this in subclassifying the curve as proximal main or thoracolumbar or lumbar, as well as modifiers for the lumbar spine, whether the central sacral vertical line is between the pedicles, apical bodies, or completely medial, as we think about the lumbar and thoracic profiles. Most patients that present will have either a type 1 main thoracic or a thoracolumbar type number 5 curve. However, it's understood that not all of these are the structural curves, and the non-structural are the compensatory curves that are associated with this. This is a curve where we can see a right-sided apex thoracic with a compensatory left, and there's significant hypokyphosis of the spine on the lateral. And this is important to understand as we think about surgical management of these in the modern day era, is not only the coronal plane deformity, but also the sagittal. This patient, as an example, was treated with pedicle screw instrumentation. And overall, you can see a significant amount of improvement in the coronal plane. The rotation, there is still some rotational deformity that is left in the patient, as well as a large degree of improvement of the natural kyphosis neutral alignment then in the TL junction as compared to the preoperative seen here on the right. This has definitely improved the spinal symmetry on the sagittal. The safety of pedicle screws is just like that of any other pedicle screw implantation case. However, it is important to understand with deformities, the visceral and soft tissue structures may be rotated, and landmarks also may be rotated with the curve. And it's important to understand that the normal position in the aorta, the vessels, may be different in more severe curves, which is important to understand. The variability of the pedicle actually can differ from left to right of the patient, as it's the concavity or convexity that has a significant amount of effect on the stress the pedicle sees. And due to that, there may be differences in each patient's morphology of the pedicles between left and right, depending on the curve itself and the stress loading. Overall, if we look at the safety of this procedure, it's overall a very, very safe procedure. This is a very large series at a Shriners, where arguably they do the most amount of adolescent idiopathic as well as neuromuscular scoliosis cases, and the intraoperative neuromonitoring alert and injury rate for specifically posterior procedures in adolescent idiopathic scoliosis is as injury rate of 0% in this cohort, which is thousands of patients. Looking overall into the freehand pedicle screw placement, especially as most of these curves are in the thoracic spine, it's found by Dr. Lenke's group that very, very safe and appropriate. In fact, that there was no complications in 3,204 pedicle screws reviewed over a 10-year course with freehand technique. Although there was violations of the medial wall, none of these were felt to be critical, with abnormalities found using both the freehand and assistance of fluoroscopy to evaluate. Although the starting points of pedicle instrumentation may be thought to be standardized for monoaxial screws, the one thing that's changed about the start points is the polyaxial screws that are routinely used. Although they may not give as much of a correction as a monoaxial can, the newer generations have the ability to have a favored angle. So these start points don't necessarily need to anatomically align as much as a monoaxial would be needed to. However, it is important to understand the start point, especially with the addition of deformity that may be present in these patients. The role of anterior surgery is certainly still discussed with especially those patients that have crankshaft phenomena in the growing spine. If there's a posterior element fusion in the spine, the growing spine will crankshaft around that solid fusion and have more of an anterior rotational effect as the patient continues to go through maturity. Those patients can benefit from an anterior surgery, as well as treating the hypokyphosis in the thoracic spine with an anterior release and fusion can have a improvement in the thoracic kyphosis. With Chiari malformations, posterior abnormalities that may be difficult or have strained anterior procedures may have a role in that. The specific type of curve, usually it's a Lenke type 5 curve that will have the most amount of correction with anterior. It does theoretically prevent larger segment fusions and preserves motion segments that may not be possible with longer posterior only constructs. As a representative example, you can see that the anterior only procedure is much larger than the posterior procedures would be in the same patient. Video-assisted anterior surgery is possible. However, it usually requires the backup of a thoracic surgeon, and usually only possible for right-sided thoracic curves, as the left-sided curves usually have the heart and pericardium in the way of getting an appropriate visualization for the surgery. Using another representative example of that anterior-only procedure, that type of right-sided truncal shift can be treated with a procedure that is anterior only and significant shorter segment than a posterior procedure has to accomplish. So the risk, there's a significant risk of bleeding in these patients. However, most of this is now controlled in modern era with appropriate hemostasis, as well as use of TXA in these patients, as well as use of cell saver. So most of the patients don't routinely have blood that is given back to them. The risk of infection and neurologic injury is very low overall, and in line with our other spine cohorts, although these patients tend to be younger and healthier overall. The use of predonation is used for blood if there is significant deformity and osteotomy to be performed with the procedure. Cell saver is used when needed and available. Hypotensive anesthesia, because these patients are younger, can tolerate much lower pressures than adult patients or degenerative pathologies. And we do use standard mechanical compression devices for prophylaxis of DVT postoperatively. Perioperative antibiotics are usually continued 24 hours postoperatively routinely. Spinal cord monitoring is always available in these deformity cases. And if there is any concern, wake-up test is done where sedation is lightened, anesthesia is lightened to the point where the patient can communicate with appropriate pain control and perform an examination on the operating table. Postoperative management is important to understand how much fluid volume the patient lost and avoid hypotension. PCA is routine or epidural anesthesia with postoperative management of these patients' pain. You can have SIH as a part of their metabolic abnormalities postoperatively with fluid shift, and vascular complications, including superior mesenteric artery syndrome, have been reported with severe curves that undergo correction and have tethering of this abdominal segmental. Postoperative management in patients that have surgical management, bracing is not necessary, as the instrumentation and implants we use have robust favor over the bracing capability. Usually patients are able to return to school within the first month, and activity restrictions with bending and lifting, twisting, usually that first 6 to 12 weeks when the bone fusion is being matured. Looking at a large database of patients that had adolescent idiopathic scoliosis surgery in their risk factors and complications in hospital. The patients that had complications, usually they were respiratory in their nature, with being prone for longer periods of time, developing acute respiratory failure, however, on the spectrum is 0.1%. And the patients that had the lowest complication rate were older teens, largely probably because their curves are more stable, and the patients obviously are at an age where physiologically they're still very healthy. The long-term success in this surgery is outstanding, with 80-90%.
Can you go back to that slide for 1 second?
Yeah.
What's HBC and LVC?
Let me see what the specifics of that one was. The slide cut off.
That's okay.
I will come back to that.
Yeah, come back.
I will come back to that. I'll come back to that. The long-term success rate is really outstanding, with most of these patients able to get back to not only school, but sporting activities, and very overall low rate of adjacent segment disease. There is a risk for that, as these patients have longer constructs into their adolescence and early adulthood. They can have. So there is always the potential risk for worrisome processes like proximal junctional kyphosis, especially. And so that really concludes my PowerPoint, and I thought I'd end with especially our faculty maybe to talk about how important the sagittal balance in these patients has become, as well as the implant density and construct designs. If we think about higher density for correction, or if we've changed in our understanding of how much is required for these curves. And then maybe in major curve corrections, how much preoperative traction is ever involved, or stage surgery, especially in those younger patients, and what the real risk of PGK has been in our institution.
Can you guys hear me? Can everybody hear me?
Yep.
Yep.
Yeah, I'll say a couple different things. People, we're so clued into sagittal balance in the adult population, and people have tried to kind of say, well, it's important in the pediatric population. You will never cause sagittal imbalance in the pediatric population, almost no matter what you do. And we learned this with Harrington rods down to L4, right, which were horrible for sagittal plane, but the pediatric spine in general is so flexible, and the ability of the patients to compensate for whatever you do proximally to distally makes, you rarely are going to take a kid, you may make coronal imbalance occur. That happens not infrequently, but sagittal imbalance postoperatively in the acute setting in the pediatric patient is really not a problem. Now, whether or not 30 years later if everybody loses sagittal plane profile as they age as an adult, and whether or not leaving someone relatively flat in the lumbar spine as an adolescent is gonna, just like the Harrington rods, is gonna be a problem. It may or may not be true, but there were a lot of girls in the 70s who got fused to L4 with a Harrington rod, and very few of them ever come back to have their fusion extended to the pelvis, although it does occur. So, and we're aware of that. We always put some lordosis into the upper thoracic spine. So I'm not really, people you go to the meetings and people go, oh, look how much thoracic kyphosis we made with our scoliosis construct, and we restored the normal sagittal balance. It's unclear to me based on any data that makes any difference to both. It may make some cosmetic difference. I don't think it makes a difference to long-term function or the chance of developing adjacent segment disease later. I think the bigger factor is how distal you go. And there was a very good study out of Scandinavia where they looked at long-term follow-up, and I mean long-term, like 20-year follow-up, because they have registries. And the thing that predicted function and satisfaction long-term for kids with scoliosis was how distal the fusion was. So the real goal now, I think, is to try to do as short a construct as you can and leave them as many motion segments open at the base. And that may be true even at the expense of having a slight increase lumbar residual curvature as opposed to making them 100% perfectly straight. So, and then you made some comments about anterior surgery. And I think, I don't poll the people around the country, but my sense is that anterior surgery is really something that very few people do anymore, because with pedicle screws, you can probably get the same results front or back, and nobody's done a prospective series. You say, well, we get more correction, and you showed that picture where they did a much longer fusion. But I look at that picture, and I'm not sure that fusion needed to be that long. And somebody needs to do a series where they do, a matched series of doing front and back over the same levels and seeing what the curves look like post-operatively, because I bet that picture you showed didn't need to go that long. And so they're saying, well, look how much shorter we could go with the front, but I'm not sure they need to go that long with the back. And so we have no data in that respect. And then the last thing I'll say, unless people have other questions, is, people talk about doing osteotomies in idiopathic scoliosis. And, I have been such a minimalist about scoliosis, and we certainly do inferior facetectomies, but, people say, oh, I do Pontes at every level. And, we published a paper, many people have published now, that implant density, you don't need to have 2 screws at every level, and you get almost the same correction with a much less dense implant. So you save money, you save time, you save risk. Outcomes are essentially the same. Same thing with osteotomies. I don't think you need to be doing Pontes at every level. Maybe in some big curves, like 90-degree curves, but certainly up to 75 degrees, I think you can use the same techniques very successfully without going crazy. I don't think we've had any PJK, period. I don't remember anybody who I had to go back and extend proximally. Had 1 or 2 people who added on distally. We went a little too short, and we had to extend their fusion more distally later. But I don't remember ever having to go proximal for proximal junctional kyphosis. So again, I think that's one of those things that people like to talk about because it gives them something to talk about at meetings, but I don't know how prevalent it really is. But that was an excellent talk. So I think you covered everything. The only other place you use anterior surgery is neurofibromatosis, which again, Chiari and syndromyellia really isn't idiopathic. It's neuromuscular in some sense, although the kids are more or less neurologically normal. And neurofibromatosis is such a rate of pseudoarthrosis that most people go front and back on those routinely. And if you could include that article that I mentioned about long-term follow-up and proximal or distal extended fusion, I think you'd have a very, very complete talk.
Yeah, I'll include that one. Thank you, Dr.
Yeah, so I think great job. I mean, I think this is a huge topic, right? And deconstructing it down, to big concepts and ideas. I think you really effectively done that really nicely. So great job with that. I agree. I mean, Gelb said, it brought up most of the really important points, right? I think a lot of times less is more. When you'll go to conferences, you'll see pedicle screws at every level, right? There's really no data set that suggests that, more screws, better correction, better surgical outcomes, right? So you have to really ask yourself why you're doing these things, right? Because there's a risk to everything you do, there's an expense to everything you do, and most importantly, there could be some morbidity associated with everything you do. So you have to keep asking your questions when you're doing your design plan for your implants. That's one aspect. I think PJK, people talk about it a bit more with regards to, sagittal plane, Schurman's disease and things like that. So I think you have to think about that a bit more. And I'm not saying it doesn't happen with AIS either, but it becomes more of a discussion point for patients with Schurman's types of issues. I think the whole goal in surgery for AIS is picking the correct level, fusing the correct level, right? Not overfusing, right? You want to always do your correction with the limited number of fusion levels that you can get by with, right? That's the basic premise. And the one thing you sort of, went over real quickly, but it's really important to understand are the differences where you're going to get in trouble, right? The different, people go into scoliosis correction thinking that they're dealing with a lanky 1, when in fact maybe they have a high thoracic curve associated with it, a high thoracic proximal, like a 2, or even a 3 where they have a double matrix curve, right? A thoracic and a lumbar curve, and they miss the lumbar curve, right? They believe it's a flexible curve and non-structural curve, right? Or they miss the structural proximal curve, right? And patients are off, right? So I think being able to delineate the nuances of a 1, 2, and 3 are super, super important, right? I think overall, even though people talk about sagittal balance, right, in the adults, at the end of the day, we know that sagittal balance, patients that have the appropriate sagittal balance tend to have better health-related quality of life scores, right? So once again, there are no long-term outcomes looking specifically at sagittal balance with AIS, but the basic premise of spinal balance, you'd rather be sagittally balanced than not, right? So it's a challenging thing to correct. If you look at, if you bring up any of those x-rays, if you just bring up any sagittal x-ray that you had in your talk, anything, any lateral x-ray, you just have one, go back up. They are so post-op. Bring up a post-op x-ray, right? They still look lordotic, right? I think they still look terrible. Just bring up any of the ones, the examples you show. It's a very, there you go, to the right. Right? Look at the rod, it's straight, right? There's really no thoracic kyphosis. Maybe there's 15, 20 degrees, right? I mean, it's probably better than it is pre-op, but it's not really normal, I don't think. Maybe, but it doesn't look perfect. So I think it's a very hard thing to do, right? The other thing that I would just bring up and add in to your talk there's a bunch of newer brace trial studies that are out there in JBJS. There's 2. Dan, we reviewed these. I can't remember the brace. I think one was called the brace trial. Gelb, do you remember these trials?
Yeah, it is the brace, BRAIST trial. That's probably the best and most recent, but it's had the same findings, basically, that if you wear the brace more than 16 hours a day, 90% chance of avoiding surgery.
Right. So you may want to include those. So just to be more up to date, I think those came out probably over the past 2 years or so, 2 or 3 years. I think Dan Sakata is the first author on that. But great job. So spectacular work.
Thank you. That one last trial looking at the NIS database, high volume centers that were doing more surgery versus the lower volume centers. Overall, no differences in the neurologic complication. Slightly different in the hospital stays for those patients, with the lower volume centers having longer stays.
Yeah. Oh, I see. Yeah. And that makes sense. You know,
Right.
the only other thing, and I always wanted to ask Gelb this. Why do we put our kids in the ICU post-op?
That's a pretty good question. And I had that discussion with the head of the PICU just recently. You know, most kids, even if you have very little blood loss, they have fairly significant fluid shifts, and they almost all get dry no matter what you do in the operating room. And then their urine output drops off post-op, in the first night post-operatively, and they end up needing a fluid bolus or something like that. They're really neurologically, it's not, we used to put them in because we thought we had to watch them neurologically, but the rate of people who deteriorate neurologically after they wake up is, really vanishingly small. But I said, so, we could probably put these kids in IMC, just so they have a little closer nursing supervision the first night. And the PICU guys were like, no, we don't think our nurses in the IMC are trained well enough, and they're not comfortable. So we want them in the
I don't
PICU.
think there's a pediatric IMC though, is there?
Yeah, there is an IMC. There is a pediatric IMC, but they said they wanted it. It was at the request of the pediatric service that we put them in the PICU.
Okay, got it. So it's
It's
just
interesting
an
in that study.
institutional issue.
If you look in that study, gastrointestinal complications were essentially the same as respiratory complications, right? 2.7, 2.8, and that's recently what we're seeing, right? Is these kids do fine, except we can't get their bowels moving. So if we could figure out something that would improve their bowel function post-operatively, that would probably be the single best thing we could do to try to speed them through the hospital, because that's lately been the sticking point for these kids, is we can't get their bowels moving.
Yeah, we've had 4 kids, maybe you've done, I don't know, 4 or 5 over the past month, right? Or more.
It's been pretty busy.
Yeah, and all those kids, I don't want to say all, but I rounded on pretty much all of them. They've all had ileuses and bowel movement issues. I feel like we should treat them like the EROS protocols for the adults and have them bring in bubble gum and start chewing bubble gum, right? Because
that's an interesting point, because so far, as far as I know, we haven't, we're not telling our patients that they can drink Gatorade the morning of surgery. I mean, I don't know that we're even doing that in the adults yet.
The prep center is supposed to be doing that. I don't know if it's actually happening now.
Yeah, we should find out, because, that's, again, they come in kind of dry, and then there's issues, and I would be very much in favor of making sure that message has gotten passed to, and we should have that message going to patients when they come to their pre-op visits. Like, we should all get together, and so make sure that everybody's on the same page. But I think we should be pushing that no need for NPO morning of surgery. You can drink some Gatorade kind of deal.
Right. And have their family bring in gum, to improve their gastric secretions and motility. Yeah. I mean, I don't think any kid's going to have a problem chewing gum.
No. But I mean, it's probably true for the adults as well. I mean, it should be across the board.
Mm-hmm. Yeah. All right, great. So great. Any other comments? So
maybe it's next division meeting we can bring that up.
Yeah, we'll talk about that.
Yeah, thanks for a great discussion.